So if you're an athlete, I mean, a runner, a dancer, anyone who does a lot of repetitive loading, you've probably felt it. That deep nagging pain right along the inside of your shin bone.
Oh, absolutely. It's a genuinely frustrating thing that just derails so many training plans.
Right. And while the pain is, very clear, the name we've been using for it is, well, it's kind of a disaster.
It's a total mess, and it's the single most common lower leg injury for these types of athletes. It started out being called shin soreness, then the very general shin splints.
Which never really took off clinically, right?
Right. Thankfully, no. And it eventually settled on this really confusing term, medial tibial stress syndrome, or MTSS.
And that's exactly where our sources today launched their attack. This deep dive is all about a pretty powerful new editorial that argues we need to just completely retire MTSS.
Yep. Throw it out entirely.
And not because the condition is rare, but because the name itself is fundamentally flawed. It's actively misleading everyone, athletes, coaches, clinicians, and it's causing some really ineffective management.
That is the crux of the issue. The second someone hears tibial stress, what do they think?
Bone, a fracture,
Yeah.
something serious.
Exactly. Their coach, even the person treating them, they immediately worry about a severe bone stress injury. And that anxiety, which is fueled by the name, it forces athletes into all this excessive rest they might not even need.
Which just leads to detraining and frustration.
Oh.
So our mission for this deep dive is clear. We're going to unpack why this rebranding is so essential, and we're going to introduce the proposed solution.
Which is LIMP.
LIMP.
It stands for Load-Induced Medial Leg Pain. It's a name designed to be clearer, more accurate, and, to actually guide treatment in the right direction.
Okay, so to get why LIMP is so necessary, we first have to really dig into why MTSS is such a huge clinical misnomer.
Right. We have to start with the problem.
So in the past, they tried to name this based on what they thought was happening, right? Like tibial fasciitis or tibial periostitis.
They did. They were trying to pin the pain on the fascia or the periosteum, that outer layer of the bone, but those names just didn't stick.
Why not?
Because the underlying pathoanatomy, so the actual tissue causing the pain, remains incredibly elusive. We just don't know for sure what's hurting.
Which is fascinating because we still have a clinical definition for it. How is MTSS actually diagnosed today?
Well, the current definition requires exercise-induced pain along that posteromedial tibial border. And here's the key part, that you can provoke by pressing on it over a length of at least 5 consecutive centimeters.
5 centimeters. That's a pretty specific detail. And that's important because it separates this broad, diffuse pain from the pinpoint tenderness you'd get with a stress fracture.
That's a key distinction, yeah. But here is the real diagnostic paradox. MTSS often relies on being a diagnosis of exclusion.
Meaning you rule other things out first.
Precisely. Clinicians will often use an MRI or a bone scan specifically to rule out a bone stress injury or something like chronic exertional compartment syndrome.
Okay, wait. Let me get this straight, because the irony here seems huge.
It is.
You're telling me that a clinician uses these advanced imaging tools to confirm that the problem is not a bone stress injury?
Mm-hmm.
And then the name they use for the condition is medial tibial stress syndrome, a name that directly implies it's a bone disorder.
That is the central problem the editorial highlights. If you've just confirmed it's not presenting like a severe bone disorder, then the name tibial stress is it's clinically inaccurate. It creates confusion and misdirects everyone's thinking.
It points you toward damage instead of load.
Exactly.
So if the name is the problem because we don't know what's causing the pain, let's get into that. What is MTSS at a tissue level? What do the sources say?
Well, this is the second massive challenge. To put it simply, studies looking at this pain have found no conclusive or consistent evidence. It is one of sports medicine's biggest unsolved mysteries, which, given how common it is pretty astonishing.
Okay, so what were some of the early theories? I know the focus was on soft tissue for a long time.
It was. The initial leading theories were all about the muscles and tendons attaching to the tibia. The thinking was that the pain was from traction, pulling or maybe friction, at the origins of the soleus tibialis posterior or the flexor digitorum longus.
And a periosteum, that bone lining, was also in the mix.
Definitely implicated. But then the research started to find contradictions.
How so?
Well, studies started comparing athletes who had the pain to athletes who were just as active but had no symptoms. And they found that the people with a clinical diagnosis of MTSS showed no greater occurrence of changes in their periosteum or tendons than the asymptomatic group.
So the tissues look the same, whether you had pain or not.
Pretty much. And if the tissues look the same, why is one person in pain and the other isn't? It really weakens that soft tissue argument.
So if the soft tissue theory is shaky, the pendulum swings back to the bone. And this is where it gets really confusing, even for clinicians.
It absolutely does, because the other trend in the literature is to just classify MTSS as a bone stress injury from the get-go. And we know this is a strong trend because of a recent Delphi study.
Okay, a Delphi study, for our listeners, that's basically a structured way to get a bunch of experts to agree on something, right?
Yeah, that's a good way to put it. It's a methodology for building consensus. And in this study, 72% of the experts agreed that MTSS was a bone stress injury.
72%.
Yeah.
That's a huge majority.
Yeah.
So why should we listen to this editorial over that kind of expert consensus? What evidence did they have?
That's a great question. And it gets to the heart of evidence versus consensus. The experts cited things like local microdamage and elevated cortical porosity in the bone.
In simple terms.
It means they saw tiny structural holes forming in the bone's outer layer, and the theory is that that reaction is what causes the pain.
Which sounds like damage. That sounds like something you need to rest immediately.
It does. But when you dig into the evidence, it's really ambiguous. For instance, that microdamage. It was only seen in 50% of the biopsy specimens.
So in half the cases, the thing they thought was causing the problem wasn't even there.
Correct. And on top of that, having more porosity or slightly lower bone density in that area can be a totally normal adaptive response to heavy loading, especially in runners. Your bone is remodeling itself to get stronger.
So it might not be an injury at all, but just
Yeah.
a painful adaptation process because maybe the training ramped up too fast.
That's the perfect summary, because the actual tissue source is unknown. Naming it based on a specific body part, like the tibia, or specific pathology, like a stress injury, is just misleading. It creates a trap.
And this is a problem in other areas of medicine, right? Like non-specific low back pain or patellofemoral pain. When you don't know the exact tissue, you have to name it differently.
Exactly. You focus on the mechanism and the location, not a pathology you can't prove. And that's where the proposal for LIMP comes in. Load-induced medial leg pain.
That's fascinating. The name is practically a prescription in itself. Okay, let's break down the three parts of LIMP.
Sure. The first part, load-induced, is the functional element. It immediately tells you the cause. Repetitive loading that exceeded what the local tissues could tolerate.
So it immediately guides you toward thinking about load management for treatment.
Instantly. It's about the how, not the what.
Yeah.
Then the second part is medial leg.
Okay.
This is the location part. It tells you where the symptoms are, but it doesn't imply a specific tissue source like tibia does. It's geographically accurate, but pathologically neutral.
But does that make it too vague? I mean, if we don't name the tissue, does that undermine the importance of, say, strengthening the tibialis posterior, which we know helps?
That's a fair challenge, but the editorial argues it actually broadens the treatment approach. If we know the pain is load-induced, the goal is to increase the capacity of all the structures in that medial leg to tolerate load bone, muscle, tendon, everything. It encourages capacity building, not just rest.
Okay, that makes sense. And what about the S word? Why drop syndrome?
A syndrome is typically a group of symptoms that happen together. But in this condition, there's really only one primary symptom, pain. So omitting syndrome just improves the accuracy and makes it simpler.
So LIMP gives us a clearer framework that fits what we actually know. Now,
Yeah.
the practical side, how does calling it LIMP actually change what a listener should do about it?
This is the biggest takeaway. The difference in management is critical. Because LIMP is defined as a load-induced issue, the management focuses on an optimal loading approach.
And what's the rule for that? How does an athlete know if they can keep training?
The protocol is beautifully simple. You can continue loading as long as it does not make your symptoms worse than they were the day before. It's a forgiving, progressive approach that lets you train with some acceptable, moderate pain.
That is a massive contrast to how we're taught to treat a real bone stress injury.
Night and day. For a low-risk bone stress injury in that same area, the rule is strict. You can only do activity if it causes zero pain, a 0 out of 10. You do not train through bone pain.
The psychological difference there is enormous. Hearing, you can train through a little pain to get stronger, versus, if it hurts at all, stop immediately.
That's the power of terminology. If you treat LIMP like a bone stress injury because the name MTSS told you to, you're going to overrest, get weaker, and get more anxious. If you treat LIMP correctly, you focus on moderating those loads while actively improving tissue capacity.
So what are those practical strategies for someone with limp? What should they actually be doing?
First, you have to look at the training structure. That means no more rapid spikes in your volume or your speed work. After that, it's all about progressive resistance training, heavy calf raises, specific eccentric work. You have to make the tissues stronger than the load you're applying.
And what about for runners? Are there any quick biomechanical fixes they can make while they're building that strength?
Yes, definitely. The research points to a few things. Running with a higher cadence, so more steps per minute and/or a higher duty factor, while at the same time reducing your stride length.
Can you break down duty factor for us? That might be a new term for some.
Sure, duty factor is just the percentage of your gait cycle when your foot is on the ground. A higher duty factor means your foot is on the ground a bit longer, but usually with less explosive force.
Okay.
And those changes, higher cadence, shorter stride, they work together to reduce the internal loading rate on the tibia right now in the short term, giving those painful tissues time to adapt.
So, to make no bones about it, the sources are clear. Changing from MTSS to limp gives everyone a much more accurate way to approach this.
It really does. Limp aligns with what we actually know. It stops us from making this misleading assumption that it's always a specific bone injury. And knowledge is most valuable when it's understood and applied.
And the name you use directly frames the entire recovery. If you call it stress, you treat it with rest. If you call it load-induced, you treat it by managing load and building resilience.
Which brings us to a final, maybe provocative thought for you to take away from this deep dive. Considering how many medical conditions have a pathology that's still truly unknown, like so much back pain or shoulder pain, how many other common syndromes out there are currently named in a way that just completely misdirects treatment, confuses the patient, and, unnecessarily dials up the fear of permanent damage?
Makes you wonder what other medical names are quietly overdue for a makeover. Until next time, keep diving deep into the knowledge. And keep moving. Optimally loaded, of course.